All right, health problems of infants. Let's talk about chapter 11. So, certain nutritional disturbances that we're going to talk about that happen particularly in the infant period of time. Some vitamin disturbances, minerals, vegetarian diets can lead to some disturbances. Food guide pyramid is sort of going away, but there are, certain nutritional needs that kids need, particularly in the infant period of time, as they're growing so rapidly. Let's see here. All right. So the most common um, disturbances would be vitamin D, which is why we recommend that children have vitamin D at if they are exclusively breastfed, they need vitamin D supplementation. This is the one vitamin that is not passed on through breast milk from mom to baby. Um, Infant formula is, of course, fortified with vitamin D, and then, of course, once they're 12 months into toddlerhood, they go transition onto vitamin D fortified whole milk, which will then fulfill that need. Um, Folic acid, another huge thing. This is particularly for those women of childbearing age, because by the time a mother realizes that she is pregnant, the neural tube is already formed, and that's a big deal. So folic acid, um, every single day for those women that are in childbearing age, so that those babies that are in utero have enough supply there when mom gets pregnant. Um, Rickets, that is a deficiency in vitamin D and calcium that we sometimes see. And then vitamin K is also given at birth to newborns to ensure that there's adequate blood clotting, because vitamin K does not start being made for several days after birth. So all newborns are given vitamin K when they are born. Um, One of the big things with this mineral disturbance is iron. This is huge. So if kids do not take some sort of supplementation, in other words, at 6 months, when those fetal hemoglobin stores are depleted, when mom's iron stores in her breast milk are depleted, we need a secondary source of iron. This can be given through foods. Iron is typically checking a hemoglobin between 9 and 12 months. It's most typically done at the 12-month visit, so right at the end of infancy. Those kids that do not have a hemoglobin of 11 or higher will go on iron supplementation. And one of the things that we encourage as nurses is to take this iron supplementation with vitamin C. This is one of the one times that I actually recommend juice, because one, most juices are high in vitamin C, and two, iron can make them constipated, and so the juice will actually help them with their stools. Um, we want to take it between meals, help with absorption, and we want to avoid taking it with milk or any sort of caffeinated drinks, with which infants typically are not drinking caffeinated drinks. Um, One of the things you'll see is iron can sort of turn their stool sort of a dark, tarry green color. And that's a normal thing. It'll make their stools hard. It definitely will constipate them. So, educating the parents about that is a big thing. We also want to make sure that we brush our teeth after giving the supplement, because it can turn their teeth gray or like a sort of light blackish color. Obviously, calcium, huge, because they're growing so incredibly fast. So we have to make sure we do calcium. All right, vegetarian diets. These kiddos need B12 and vitamin D checked. especially those kids that are on strict diets because they're not eating eggs or things like that, which are also fortified. And eggs are a very big source of B12. So two things, two sort of protein slash energy malnutrition that thankfully we do not see here very often, unless in the case of an extreme neglect. Kwashiorkor is that deficiency in protein, but they have adequate supply of calories. So these kiddos are the kids that have the wasted extremities, and they have large abdomens. So they have those protuberant abdomens. These kids have very thin, dry, coarse hair, and their heads look too big for their bodies, and their stomach is the largest part of their body, and then their extremities are extremely wasted. Whereas marasmus is the deficiency in protein and total calories, and these are the children that look severely malnourished. They are very, very rail thin. You can see their bones and things like that. Different food sensitivities and allergies. The most common allergies: cow's milk, eggs, and wheat. And like I had mentioned before, now we're seeing more and more literature come out on allergies and the infant, and how introducing some of these high allergy foods can actually be somewhat protective. So for instance, eggs and peanut butter and wheat is recommended to introduce around 9 months now. You introduce it very, very slowly, but the earlier introduction is showing that there's protection within that infant period to help minimize that allergy from presenting itself. So we're doing that now. We're introducing those foods a lot earlier. Cow's milk allergy. This is going to be the most common. So these are the kids that have bloody stools. That is a true milk allergy, is going to present with blood in the stool. And this is common in infancy. And it's actually not a permanent thing. In other words, a child who has a milk protein allergy in infancy doesn't mean that they're never going to be able to eat ice cream. But ice cream might upset their stomach, or they might have some sort of sensitivity to it their entire life. These kids with that true milk allergy oftentimes are also allergic to soy. So the diagnosis of this is typically done by complete elimination. If they do have a true milk allergy, then those kids get put on a specialized formula, which is amino acid based, which is such as progestamil, Nutramigen, Alimentum, things like that. Different feeding difficulties that we see in the infant period would be sort of spitting up, right? So dribbling of unswallowed breast milk or formula. You have that happy spitter versus that child who has reflux. That happy spitter is a laundry problem. In other words, they spit up after every feed. They're not bothered by it. They're happy. They're smiling, and they're just spitting up. They're growing, and that's a huge, huge thing we have to make sure. They're growing well. Because if they're spitting up, they're still ingesting enough to where they're growing, they're staying on their growth curve, they're fine. Versus those kids who have severe GERD, they're unhappy, they're arching, they are spitting up, they're not eating well, and they may not be growing well. That's the severe GERD that we worry about. So making sure that these kids are growing, that they're comfortable. So we can do Zantac, making sure that they're sitting up for 30 minutes after feeds, giving them a formula that, like a gentle ease formula, if they're on formula, having mom eliminate milk and spicy foods and things like that will also help with the GERD. All right, so yeah, so burp often, so smaller amounts, burping more often, keeping upright, elevating the head of the bed, and then sometimes we have to do medication such as Zantac to help the babies. All right, so let's talk about colic for a minute. Colic is different than reflux. Reflux babies can be uncomfortable. They can cry after feeds and things like that. Colic is when affects about a third of babies, if up to a third of babies, it typically presents around 6 weeks of age, and it's typically gone by 3 months. Remember me talking to you guys about that fourth trimester? Really, babies need to stay in the womb for about 12 more weeks, right? Well, this is one of those reasons. The neurologic system, the gastrointestinal system, all of these things are sort of still innervating. They're still maturing, and colic is sort of a result of that. So up to a third of infants can experience colic, which is quite a bit when you think about it. Um, Babies that have colic, the way it's diagnosed is diagnosed on history. Their entire testing. So if we were to take this baby and do a CT scan, abdominal scan, X-rays, blood work, everything's normal. These kids are normal. They're growing well. They're otherwise happy infants, but these kids cry for an extended amount of time, to 3 hours, without stopping, typically around the same time of day, every single day. It doesn't matter what you do to help them. Like I said, they tolerate feeds, they gain weight, and they're usually thriving. They're happy, they're meeting milestones, they're doing everything they should that other infants are doing, but they have a period of time where they cry and they cry and they cry, and it is loud. What do we do? Investigate the problems. Like I said, we make sure the baby's fine. Make sure everything is okay. So diagnosis of exclusion. In other words, this baby is completely normal. Now, these babies that are going to come in that are going to have colic diagnosed, we're not giving them the $1 million workup because it's not needed. Frequent changes in position. Like I said, simethicone drops, massaging the abdomen, vibrating, rocking the baby. Car drives might be helpful. And then really close follow-up with parents. So babies that have colic have the highest rate of infant shaken baby syndrome. Obviously, just stop crying, right? Put the baby down and walk away. These parents need to be given permission to put the baby down and walk away and let them cry. The baby will be okay. Failure to thrive, okay? These are the babies that are not meeting milestones. They're not growing. Their weight's falling below the 5th percentile. So different reasons why we have kids that are not growing, or the technical term, are failing to thrive. Organic. So there's some sort of physical defect that causes this, such as a cardiac defect. So these babies aren't able to eat enough. They can't take in enough calories to grow appropriately. Nothing that the parents are doing wrong. They just can't do it. Non-organic failure to thrive would be sort of an unrelated, a definable cause unrelated to a disease. In other words, psychosocial factors, okay? And then idiopathic would be unexplained. There's really no we can't explain why they're not thriving. Huge clinical manifestations of failure to thrive. So a baby that is failure to thrive. In other words, these babies are not doing what typical babies should. They're not growing the way typical babies are. They don't make eye contact. In other words, socially, they're disconnected. They're not involved. They're not engaged. That is a huge red flag when we see babies in the hospital or when we see babies in the outpatient settings. Other manifestations would be growth failure, developmental delays, apathy. In other words, just they don't really care about anything. Withdrawn, fear of strangers, avoidance of that eye contact, radar gaze. In other words, they just sort of stare off. Okay. And then weird body posture. So stiff or flaccid, unresponsive.